Tonight, with webinar support from Mead Johnson Nutrition, Neanne continues our commitment to highlight the work of our regional nursing experts. This spring, Dr. Britt Pados claimed cover girl status on the Boston College magazine. She began her educational journey at BC as a 2003 BSN graduate before pursuing her master's degree as a neonatal nurse practitioner at the University of Pennsylvania. Ultimately, she was awarded her PhD at the University of North Carolina, Chapel Hill. Britt has since returned to Boston College as an assistant professor in the School of Nursing. There, her work as a neonatal nursing scientist focuses on feeding difficulty in infants and young children with medical complexity, particularly those who are born preterm and/or with congenital heart disease. On behalf of Neanne, let's welcome Dr. Britt Pados.
And I would like to acknowledge that this work has been funded by a variety of different funding sources as listed here. I would also like to acknowledge that while I'll be talking almost exclusively about bottle feeding, this week is World Breastfeeding Week, and I am a staunch supporter of breastfeeding and the provision of human milk when breastfeeding at the breast cannot be achieved. And as we know, many of our NICU babies are not able to do at breastfeeding 24 hours a day. So really, today is talking about how we can support those babies who need to be fed by bottle and do that in the safest way possible. Our objectives for today are to explain a little bit about how and why milk flow rate affects physiologic stability in infants, describe some of the available flow rate research for nipples used both in the hospital and after discharge, discuss the effect of thickening on flow rates, and then talk about some opportunities for improving the safety of oral feeding in the NICU. So as I'm sure pretty much all of you know, our babies in the NICU often experience difficulties with oral feeding. That can be related to respiratory disease, difficulty coordinating sucking, swallowing, and breathing. Particularly for our premature babies, there may be some component of immaturity with regard to their neurologic or gastrointestinal tracts. Many of these babies, especially those requiring long-term NICU stays, have a lot of negative sensory experiences involving their face and mouth. So things like endotracheal tubes and orogastric and nasogastric tubes, even the tape that we use to maintain tubes in place that really restrict the movement of their face and mouth. And even things like other respiratory support like CPAP, where we're really restricting the natural movement of that baby's face. So many of those babies who have particularly long-term NICU stays go into feeding with a lot of negative sensory experiences around their face and mouth. Some of our babies are at risk for dysphagia and aspiration, especially those who have had either endotracheal intubation, where they may have direct trauma to the laryngeal structures, and then particularly babies who have had a surgical PDA ligation, ECMO cannulation, or any type of surgical procedure involving the aortic arch. Those babies are at particularly high risk for vocal cord dysfunction. And then any baby with any degree of physiologic instability may have difficulty sort of managing the demands of oral feeding on top of maintaining their stability. How we feed babies in the NICU affects their long-term feeding. So, we use terms like cue-based and infant-driven and co-regulated to describe feeding, and those are relatively new terms, but that does not necessarily translate to the practice of optimal feeding. Optimal feeding, really the foundation for that starts long before the first time the breast or bottle is presented to the baby. And I actually have a new paper that just recently came out that talks about some of the things that we can do even before the first feeding to support babies being ready and really having optimal skills going into oral feeding. I'm happy to share that with anyone that's interested. And really, we need to make a little bit of a culture shift in the way that we approach feeding. And I recognize that feeding is challenging and There are a lot of different components that go into making a change in culture, but really feeding needs to be safe. So it's not okay for babies to desat and brady or cough and gag during feeding. When they do those things, they're telling us that feeding is not safe. You know, there are some NICUs who feed babies off of monitors. And that's because I think those events, or at least my understanding is that those events are sort of seen as not counting, if you want to put it that way. But really what we need to know that babies are having these types of events when they're feeding, because they're telling us that it's not safe, and they're telling us that they need more support in order for feeding to be safe. Feeding needs to be a positive experience for both the baby and the parents. If you think about those early months of life, much of the parent-child interaction is happening around feeding. And when that is stressful for both the baby and the parent, that's going to affect their long-term parent-child relationship. Feeding needs to be energy efficient. So we need to support babies in a way that allows optimal balancing of that energy in versus energy out so that we can support their growth. And we really have to, focus on establishing appropriate feeding practices for parents and babies in the long term. These parents learn how to feed their babies in the NICU. And sometimes our goal in the NICU is a little bit different from our goal after they get discharged. But parents use those same strategies. So we need to make sure that we're teaching parents to really be reading their baby's cues, understanding what those cues mean, how to support their baby, not just while they're in the NICU, but then moving on beyond the NICU. And changing feeding culture is a challenge, but we do need to do better, and I'll tell you a little bit why I think so. So some recent research shows that after discharge, 42% of children who are born preterm, and these are all babies under 37 weeks gestation, experience problematic feeding in the first 4 years of life. This was a meta-analysis of over 4,000 preterm born children. And this paper is currently under review, so keep an eye out. And really, this is probably a conservative estimate because many of the studies that were involved in this meta-analysis actually excluded babies with significant medical comorbidities and excluded infants and young children with severe feeding problems. So that's a really significant number of children who are going on to experience problematic feeding after they leave the NICU. Other recent research has found that very preterm infants, so those born at less than 32 weeks, have more symptoms of problematic feeding in the first 7 months of life compared to those born at later gestational ages. And this difference actually remains as they get a little bit older, so that difference between those born at less than 32 weeks versus those born at older gestational ages holds true even when they're 6 months to 7 years old. And we sort of have this idea in the NICU that babies start to feed and then they get better and better and better until they reach the point where they're successful enough to go home. And I think that many of us, and I know this was true for me, thought that they got better and better as after they went home. But as many of us who see babies in the neonatal follow-up clinics or in feeding clinics after discharge know, many of these children go on to struggle with feeding for a long, long time. So the way that we feed babies in the NICU really does impact their long-term feeding, and I do think that we need to make some changes in the way that we approach feeding to support them in the long term. The reason why we're talking about milk flow today is because I do think that it's one of the most simple changes that we can make that can have a really significant impact on feeding for babies. It's easy, so it doesn't require any additional work to choose one nipple over another and screw it on. It requires no additional training. So there are lots of special feeding courses that you can take. But this doesn't require any of that. It doesn't require the time, the money, or sort of the effort to go through that process. It's also consistent from one feeder to another. And this you know, there are a number of other interventions that we can use to support feeding in the NICU. But many of them, you know, can be a little bit different from one feeder to the next. So the way that one person might hold a baby in a sideline position is a little bit different from the next. Or the way that one person might pace a baby at feeding is going to be a little bit different than the next. And the nice thing about changing milk flow rate and being consistent about that is that it really is consistent for that baby over time. And I'll talk a little bit about why variability in feeding is important when babies are learning to eat. Babies can also go home using the support that they need. So I have heard from people that, you know, there's an idea that a baby needs to be successful on a standard flow nipple before they go home. And there's really no data to support that idea. And actually what I'll show you in just a little while is that the flow rate of the standard flow nipples that we typically use in the NICU that are disposable products are actually really quite fast compared to many of the products that are intended for babies 0 to 3 months old. So there's really no reason why they need to transition to that standard flow nipple before they go home. And they can go home on what they're able to be safe and successful at feeding. So what are we talking about when we talk about milk flow? We're talking about the rate at which the milk transfers or moves from the bottle to the infant's mouth during feeding. And there have been some studies that have shown that the rate of milk flow affects the degree of ventilatory compromise experienced during feeding of both term and preterm infants. And I recognize that these two studies are actually really quite old at this point. Unfortunately, we don't have a lot of more recent research that has looked specifically at this. There was a study done by Dr. McGrattan that was published in 2017 that looked at the effect of flow on respiration. But unfortunately, the products that they used, the slow flow condition was really very fast and highly variable. And I'll report on that in a few slides. So that, you know, I think the lack of difference that they found in that study was likely related to the small sample size of 13 that they had, but also unfortunately, the products that they chose. This is a really simplified explanation of a very complex process, but ultimately the reason why milk flow rate affects respiration is because of the common anatomy at the level of the epiglottis. So when a baby swallows, their epiglottis and their vocal folds need to close so that the fluid moves into their esophagus and is protected from their trachea. And so they have to hold their breath for about 1 second with each swallow in order to prevent aspiration. So when milk flow is high, it means they need to swallow more. That means their respiration is more interrupted. They develop more fatigue. They're at higher risk for aspiration. On the other hand, if we slow down milk flow, their swallow is delayed. They're able to breathe more, have less fatigue. They have more time to coordinate a swallow and clear the bolus from the back of their throat, reducing the risk of aspiration. And it also promotes the development of the oromotor musculature to support later, more complex feeding and speech. So some of the research, you know, that has looked at healthy full-term infants has shown that they are really very resilient. So they're able to manage, many of them are able to manage high flow rates by either changing their sucking rate or their sucking pressure in order to regulate the flow. And then when they pause from sucking and swallowing, they pause, and then they can use sort of increased respiratory rate to catch up on their breathing. But what other research has found is that babies with medical complexity are less resilient. So they may not be able to alter their sucking rates or pressures. And if they have underlying cardiac or respiratory disease, they may be unable to catch up with breathing during the pauses. And so if we think about a swallow taking a full second or having their airway closed for a full second, when we have babies who are tachypnic at rest, so if you have a baby who's breathing 60 times per minute, That means they're taking 1 breath every second. So every time that baby swallows, they have to give up a breath. And so as respiratory rate increases, or their need for respiration increases, particularly at rest, it becomes increasingly challenging for that baby to fit in a safe swallow between their breaths. And also they will eventually become oxygen hungry and then need to take a break from feeding. And really, many times that could be the end of that feeding for that baby. So this is a video that shows some of the intraoral movements.
Was filmed when the same baby was sucking water containing sucrose using a nipple with a small hole. This time, the baby opens his mouth more widely, but the tongue movements are similar to those when using a nipple with no hole. The third part was filmed when the same baby was sucking water containing sucrose, but using a nipple with a large hole. As a result, the baby has to drink rapidly and has no need to squeeze out the fluid. Now there are no clear tongue movements. The baby has changed the movement of his tongue according to the condition of the nipple to minimize the energy required. This diagram illustrates.
So I think that's a really nice illustration of what's actually happening inside the baby's mouth. That also is a pretty old video, but we don't have anything much better at this point. So if milk flow is too fast, babies basically have 4 options. They can either choose to stop feeding, they can swallow at a frequency adequate to clear the oropharynx and prevent aspiration, but that may come at the expense of ventilation. They can allow milk to pool in the oropharynx and therefore risk aspiration. Or they can divert excess milk away from the oropharynx by allowing it to drool out of the side of their mouth. So what does this look like to the feeder? So that the baby who needs to stop feeding is going to look like a baby who's refusing. So they're going to pull away, they're going to push away, turn their head, close their mouth. You know, and babies, although they can't talk to us, they do tell us with their behavior what they need. So they're actually really quite smart, and we need to give them the credit that they deserve to tell us what they need when it comes to feeding. A baby who's swallowing at the expense of ventilation is going to have apnea, desaturation, bradycardias. Babies who allow milk to pool in the oropharynx and risk aspiration may show signs of choking, gagging, coughing, although many times, and the research is pretty consistent about this, many times in our young babies, aspiration is silent. So we really may not know that that is what's happening, other than we'll likely see desaturations if they are on a monitor. Or they can divert excess milk away from the oropharynx, allowing it to drool out the side of their mouth, which is going to look like drooling or pooling in the cheek. Particularly if they're on their side, you might see a baby who then sort of has this amount of milk that comes out of the mouth after the bottle comes out. And really that drooling of milk is a compensation that the baby is making. You know, it's aside from babies who have really significant neurologic or anatomic changes of their mouth, drooling is almost always them compensating for flow that is too fast for them, that they're not able to swallow fast enough while maintaining ventilation. And so using things like chin and cheek to support to make that baby swallow that milk is actually putting their airway at risk. So we really, the chin and cheek support in order to stop drooling is something that we need to think about really carefully about why we're doing that. And if we can change the flow rate of the nipple to help that baby manage the flow better, that will certainly be safer for them than sort of forcing them to swallow. So there were some early studies done in the late 80s, early 90s by someone by the name of Matthew that looked at milk flow rates from bottle nipples. They found that the milk flow correlated with the size of the nipple hole and really found high variability in flow rates among nipples of the same type. And that infants used lower sucking pressures when feeding with high flow nipples. After a period of time, Jackman did a study that was published in 2013 that evaluated flow rates of 25 different nipple types used in the NICU. And she found that there was wide variability in the flow rates of the nipples that were tested, but the major limitation to that study was that only one nipple of each type was tested for the multi-use nipples, and for the single-use nipples, only 3 of each type were tested. So when I started this work, I really felt like clinicians needed information, updated information, about current products, about milk flow rates of nipples to make informed decisions to support oral feeding in the hospital, and then to guide parents in making decisions about the products to use after discharge. So I developed a method that I use now for a variety of different research studies to test flow rates. And to do this, we attach a breast shield of a breast pump, attach a nipple to the breast shield with parafilm and a silicone-based polymer. It's positioned, as you can see, at a 30-degree angle. For consistency, I've primarily used Similac Advanced Ready to Feed formula, not for any particular reason other than it's readily available and to be consistent across studies. We have found that over time with the exposure to air, formula actually thickens. So much like if you take heavy cream and you were to shake it over a period of time, it eventually turns into butter. The same thing, interestingly, happens with formula if you continue to manipulate it over long periods of time. So we've determined that it needs to be changed about every 10 tests. Oops, sorry. We've also developed a way of making sure that we have consistent hydrostatic pressure. So that's the pressure of gravity actually forcing the milk out of the nipple. So we need to make sure that that's consistent across tests, particularly when we're comparing standard neck nipples to sort of wide neck nipples. Then historically, we've used Medela pump and style advanced breast pump on the stimulation phase, testing the suction pressure to make sure that we have consistency in that about every 50 tests. What we do is express the formula into a glass beaker on a calibrated platform scale. And all of the tests, and this is really a critical piece of the study, all of the tests are actually video recorded, and then we review the videotape to record the exact weight on the scale at 1 minute, and then calculate milk flow in milliliters per minute by the density of formula. This is a fun little video, just a short clip. So you can see the pump actually extracting the formula there. And one important thing to note is that currently the testing so far has not been intended to mimic a baby feeding at the bottle. Really what I have tried to do is establish really consistent methods so that we can compare flow rate from one nipple to the next. But it's not, the flow rates that we record are not necessarily what a baby would achieve at that bottle, mostly because every baby uses different pressures and sucking rates between feedings, even within the same feeding and in between babies. So it's really hard to know what any given baby would actually achieve at a given bottle. But the intention here is to be able to compare one to another. And here on this slide, I reported on the test-retest reliability. So we found that we're very, very consistent when we do one test and compare it to another test of the exact same nipple. It typically reported just descriptive statistics, mean milk flow rates and standard deviation. And then the coefficient of variation is calculated as the standard deviation divided by the mean. And what that tells us is how variable a nipple is within that nipple type. So for example, if I pick one Similac slow flow nipple and then I pick another Similac slow flow nipple, the coefficient of variation tells me how similar those two are to each other, taking into account sort of the mean flow rate of all of the Similac slow flow nipples. So I've sort of created this designation of low variability, meaning a coefficient of variation less than 0.1 or a 10% variation. Moderate variability being 0.1 to 0.2, so 10 to 20% difference from one nipple to another, and then high variability being more than 0.2. This was the first of my papers that came out on this study, and we looked at 29 different nipple types. These were used in primarily hospital-based settings and tested 10 of each nipple. So that was determined by power analysis so that we ensured we had an adequate sample size. And what we found here was that there was really incredible range of flow rates of the products that we tested. So from, as low as something like 3.39 for the Dr. Brown's Ultra Preemie up to 85.34 for the Dr. Brown's Y-Cut. And I just mentioned here, I don't think that the Enfamil crosscut data that was reported in this paper was valid, mainly because the method that we use applies only negative pressure and not positive pressure. And if you apply positive pressure or press down on the end of a crosscut nipple, you notice that the size of the crosscut changes significantly. So I don't want you to use that data. And this actually is quite old at this point, so I would recommend you use the more updated data. What we also found in that study was just really incredible variability between products. So, there were some products that seemed to be very consistent. So if you picked one nipple, it was very similar to the next nipple that you tested of that same type, whereas others, could be as much as 40% different from one nipple to another. And I think this really opened my eyes as a neonatal nurse that, typically when a baby fed well at one feeding and then didn't feed well at the next feeding, I assumed that that had something to do with the baby, that maybe they were fatigued or something else was going on, but I think what this study made me realize was that the variability in these nipples may be playing a really big role in how a baby does at one feeding versus the next. So if I fed that baby at that first feeding with a slow flow nipple that happened to actually be slow, and then at the next feeding, even though I picked the same type of product, but it was a disposable product, so I used a different nipple, even though it was the same name, it could be a very different flow rate, and that could have been contributing to how that baby fed when they didn't feed well. When I looked more closely at that data from that first study, comparing the nipples that were identified as slow flow nipples, I found that really there was a pretty wide range of what slow flow meant. So, there was this group of nipples that was around 3.5 to 4 milliliters per minute, whereas the Enfamil slow flow was just about 3 times more than that. So it was around 15 mLs per minute. And then again, same story when we looked at what was identified as premature nipples. So, the Dr. Brown's Ultra Preemie and Preemie were quite slow. The Similac premature, also known as the red nipple, as I think many of us suspected, was really quite fast. And then the Enfamil Preemie, which I don't believe is being sold anymore, was very, very fast. And I think this was based on the idea that that we had a while ago, that if a baby was having difficulty with feeding, we should make it easier for them. So try and increase the flow rate to make it easier so that they can feed more before they get tired. And really our thinking about that has changed significantly to what I was saying before of if we slow down the flow rate, we let them breathe more, then they'll get less tired and, and then they'll be able to feed more successfully. And I think the other component of that is that we need to think of every feeding opportunity as a learning experience for that baby. So we want feeding every single time to be as positive and constructive as it can be, knowing that that baby is building up their feeding experience. And so, being really cognizant of that. The next study that I did was published in 2016 that looked at 26 different nipples. Dr. Brown's products overlapped between both of these. And this was really intended to help give us some idea of what the flow rates were of products available to parents after they left the NICU. And as you can see here, there is just an incredible array of products available. And we do need to provide them with some guidance that is based on evidence. So we pretty much found the same thing. There was pretty incredible range in terms of flow rates of products. And again, also really significant variability amongst certain products. And I'm not going to spend too much time on that because we have more updated data. So the most recent paper, and actually if you want to scan the QR code that is on this the screen right now, Advances in Neonatal Care agreed to make this paper freely available for the month of August. So you're welcome to go and download that. So this was the most recent paper that was published in 2019. For this, we tested 25 different nipple types and actually increased our sample size to 15 nipples per type. And we intentionally chose products that were used in the NICU and then actually looked at the top 6 major infant product retailers to choose products that were available across the United States in different price ranges to make sure that the data was useful to the most parents. And one of the interesting things that we found in this was that there were 215 unique products by 52 different brands. And this is old now too, because since then, a lot of other products have come onto the market. But really, parents are faced with overwhelming numbers of choices. And I actually am a mom of premature twins, and I remember having to go to Babies R Us when the babies were still in the NICU and I needed something, and I was postpartum and I was stressed and I hadn't slept and I had these 2 babies in the hospital. And I just remember standing there and crying in the aisle thinking, how am I supposed to make any type of decision right now? And so we really need to help parents with these decisions and know that really the decisions that are made are going to hopefully support their continued learning after they're discharged. So this is the data that was published in that 2019 paper. Again, like really significant range between different products. So we have some of the Philips Avent natural products that are really very slow, whereas something like the Medela Coma, it's really quite fast. Even the Medela Wide Base Slow, which is the nipple that is sold with most of the Medela breast pumps, is also really quite fast. I will note that there are 2 nipples that are included in this chart in this presentation that are not part of the publication because they were tested since then. So the Enfamil Extra Slow and the Dr. Brown's Newborn were new products that came on the market since that publication. So a couple of things to note here. So here I have highlighted the Enfamil products and the Similac products. And what I want you to note, one, is that like I said earlier, the Enfamil standard flow and the Similac standard flow are both about 19 milliliters per minute. And this is really quite fast compared to many of the products that are available and intended for infants between 0 and 3 months old. Other things to note, here we see the Similac standard versus Similac premature. So really quite similar, and actually the premature was a little bit faster. And then also to note, so the Philips Avent anti-colic, 0 months plus, had a flow rate of 17 milliliters per minute, while the Philips Avent Natural 0 months plus had a flow rate of 2.25. So same company, same brand. On the product itself, they both say 0 months plus and look exactly the same other than the shape of the nipple itself. But really incredibly different when it comes to flow rates. So if you have a parent that says, oh, I'm feeding my baby with an Avent 0 months plus, we really need to know what type that is to know whether that is slow flow or really quite fast. Similarly, we found significant variability amongst a lot of the products, with most of them following in that sort of medium to high variability range. And when we look specifically at certain products, so the Similac, like I mentioned, the standard and premature were not different from one another, but the slow was significantly slower than the others, and these were moderately to highly variable. The Enfamil products, so the extra slow, slow, and standard, were all significantly different from each other and were in the order that we would expect them to be. Enfamil standard had low variability, while the other two, Enfamil slow had moderate and Enfamil extra slow had high variability. When we compared the Dr. Brown's to the Infant Labs products, we found that the Dr. Brown's newborn and infant standard flow were statistically the same, while the others were different from each other and in that order. And then I did a cluster analysis that sort of identified 5 unique distinct clusters of nipples, and you have these on the slide, so I won't spend a lot of time on them, but basically a group of nipples that could be considered extra slow, slow, medium, fast, and then the medulla, being very fast. And I will note that, so the pressure that was used across all of these tests were the same. The way that the medulla, product works changes flow rate, well, I'm actually not sure if it changes flow rate, but in order to establish flow rate from the medulla, a baby would have to achieve a certain amount of suction pressure to sort of move the nipple away from the base of that product. So just keep that in mind in terms of how this was the testing that was done for this flow rate. Some exciting and new research that is currently under review and hopefully will be out soon looks at the effect of thickening on flow rates. So, one of the questions that I get all the time is, well, if we need to thicken, what nipple should we move to? And, I hear some places sort of automatically going to like a level 4 if thickening needs to be done. So I really felt like we needed data to guide those decisions. So I tested 7 different nipples with regular formula and then 2 thicknesses using gel mix, since gel mix can be used with breast milk and is one of the products approved for the neonatal age. But I only tested slightly thick, also known as thin nectar, and mildly thick, because moderately thick or honey thickness is not recommended for infants under 1. So, this data will be coming out shortly. But what we found here is that, as we expected, flow rate decreases with thickening. And now we have a little data to guide us. So if a baby, for example, is feeding well on regular formula or breast milk using an ultra creamy nipple, and we need to thicken to slightly thick, we can go up to a newborn nipple, and that will achieve approximately the same flow rate. So we can use this data to sort of make decisions based on how a baby was feeding prior to thickening and then the thickness that is needed. I will note that the mildly thick formula did not flow through the ultra creamy nipple, so that's why that is not shown there. Another really significant finding of this particular study was that as we increased thickness, the variability in flow rate changed significantly. So as we expected, thickening decreased flow, but, and this is, you know, thickening has been found to be a really inconsistent intervention. So the different products that are used in different NICUs, and even within the same product, over time, the thickness changes. In some cases, it becomes thicker as the milk cools down. In other places, it actually sort of degrades and becomes thinner over time. And so thickening as an intervention is really currently a very inconsistent intervention and does not always offer sort of the level of safety that we might want. So if we can achieve safe feeding by just changing the flow rate and without thickening or manipulating the milk in any way, I really think that that would be best. We also don't know the effect that these different products have on the microbiome of the baby. And I think that's a really, you know, introducing anything unnecessary to a baby's gut, particularly our premature babies who have immature GI tracts, should be avoided if we can find another safe way to feed that baby. And, you know, the fact that thickening resulted in increased variability is really important when we think about babies who are learning to eat. So when we think about somebody learning any new skill, learning occurs more efficiently when it's done under consistent circumstances. So a baby who's learning to walk, for example, you know, if they're always learning to, if most of their early learning happens on a hardwood floor in bare feet, then they figure out how to move their feet, how to move their legs, how high to pull their foot up off of the ground. Whereas if one day one time they're learning, they're in shoes and then they're in bare feet, or they're on carpet and then they're hardwood and then they're on tile, they constantly have to be sort of renegotiating with their body about how to make that be successful. And that's really the same with feeding. So if every feeding we're using a different nipple, or we're using the same nipple, but it's highly variable and therefore has different flow rates. Or if we start manipulating the thickness and that increases the variability, then that baby is constantly trying to learn how to eat under varying circumstances. And so, you know, what might be successful at one feeding in terms of the way that they coordinate their sucking, swallowing, and breathing, or the sucking rate and pressure that they use, is going to have to change with the next feeding if it's done under different circumstances. So I really think, and we need data to support this, that consistency and decreasing variability, whether that's from products or other manipulations to feeding or even feeders, that will help them to learn more efficiently. So this is just something else to think about as we consider whether thickening is the right intervention to use in a baby who's learning to eat by mouth. A very recent study that I did looked at how flow changed whether we were using ready to feed versus powder formulas. This also will be under review soon, and so hopefully out very soon, but just a little teaser here. So there were no differences in flow between the standard formulas regardless of preparation. However, when we moved up to the sort of spit up or anti-reflux formulas, the powder formula flowed significantly slower than the Similac ready to feed. And that was true for both Similac and Infamil. We also found differences between sort of the standard formulas and those spit up or anti-reflux formulas based on flow rates. So something else to think about that could potentially affect flow and therefore also affect the way that a baby feeds. So can we just turn it over and see how fast it drips? That's another question that I get asked all the time, and actually we looked at this, or we tried. And in this case, we needed to use vacuum-free bottles. So we used the Dr. Brown's bottles, but we're testing different nipple products. And the reason why we needed to use vacuum-free bottles is because if you turn a bottle that is not vented upside down, it will eventually, the pressure inside the bottle and outside the bottle will eventually equilibrate and it'll stop flowing. So in those cases, it will look like slow flow, even though really what we're seeing is just an accumulation of pressure within the bottle. So this is just a little video showing, these are all the same nipples, showing the difference that we could see in terms of variation of flow between the same nipple. But here's where you can see sort of the major problem with this. So when we tested these products that were not intended to be used with the self-venting bottles, we got a lot of dripping around the collar. You can see it dripping sort of down the nipple, not necessarily out of the hole, but sort of out of different places. So, you know, what we determined was that the drip test only works for nipples that fit on self-venting bottles. And then there's so much variability in terms of how that testing is done that we've, you know, but ultimately drippy does not necessarily mean that something is fast flow. And just because something is not drippy does not mean that it's slow flow. So turning it upside down and testing the flow rate is not an accurate way to measure flow rate. And currently, I think my methods that I've developed so far are the best that we have, but certainly have limitations as well. Some incidental findings that I thought were really interesting. Some nipples actually had no holes. So if you have a baby who really looks like they're doing great at feeding and they're sucking and sucking and sucking, and then you turn it over and you say, wow, they didn't take anything, check and see if it has a hole. That was pretty astounding. So when you are attaching the collar to the bottle, if you tighten it too much, it actually alters the venting of that nipple, and it creates suction within the bottle. So as the baby sucks, it actually creates suction within, and it's not able to sort of release that pressure. And this can be misinterpreted as the flow being too slow. So really, as we tighten a nipple on, it really just needs to be tight enough to keep it from leaking. Other kind of interesting things, a full bottle. So for example, if you use a ready to feed 60 milliliter formula bottle, will have a higher hydrostatic pressure and therefore faster flow than the same bottle with only 30 mLs in it. So, you know, for most babies, this may not really make a difference. But for those really, really vulnerable babies who have a lot of difficulty handling flow, really putting a very small amount of milk into the bottle is going to help them as well. At the same time, as the amount of milk is reduced, it actually becomes more challenging to extract the milk because of that hydrostatic pressure. And so just keep that in mind. And as I mentioned, thickening is a really highly variable intervention. Some limitations to this work. So as I mentioned, any product that has a crosscut is likely our application of only negative pressure is a significant limitation to setting those products. There's a bunch of other factors like compressibility and elasticity of the material that go into flow as well. So I'm looking into that now. And you know, the products are always changing. And so far, the pressures and rates that I have used in these tests have really been limited by the pump that was used, but new options are available and will be changing soon. So some conclusions. Our nipple choice is really important given the wide range of flow rates that have been found across these different studies. So what we choose really does make a difference. The name of the nipple doesn't always accurately indicate the flow rate. And you know, these data are really helpful in helping us to make decisions about products to use to support feeding, particularly in our vulnerable babies. So we should start slow, safe, and be consistent. You know, I there are some places that go sort of on give them a standard flow nipple until they decompensate and then drop down to slow flow. And I really think particularly for our very vulnerable babies, we need to be starting very slow and then progressing as needed. And then take into account other changes like thickening and preparation when considering whether flow rate is altering a baby's feeding. So lots of future directions, but I want to make sure that we have time for questions. This is my contact information. It's on the slides that were shared with you and will be shared later as well. And there's also a long reference list. And I am certainly happy to share any of those papers with you if you would like. So thank you.
Well, thank you, Britt. On behalf of all of us at NEAN, I can't tell you how much we appreciate your presentation tonight. It is really an honor to have you share so much incredible information with us. And I know there are lots of people on the presentation who have lots of questions for you. So I'm going to suggest that this is really the time for those burning questions. You know, the ones we think about every time we feed a baby who's struggling, and this is our expert time. We're going to have a limited question and answer period now to be respectful of the hour, but after we've shared our evaluation information, we'll return to Britt and more of your questions if you'd like. If you have a question, please type it into the chat. And what we'll do is just in the order that they come in, we'll present them to Britt for more discussion. Let's see. So the first question is coming in from Anonymous, Britt, and it, have you looked at the flow rate of the Tommy Tippy extra slow flow?
So I actually just purchased all the products for the next round of testing, and that will be in there. So coming shortly.
And Sally is asking too if there are any thoughts on thickeners affecting constipation, especially long term.
I mean, as I've mentioned, I really have a lot of concerns about thickeners for a variety of reasons, but and constipation is one of them. Constipation, reflux, and other GI distress is another area of my interest, mostly because in the work that we've done looking at feeding in children after the NICU, we almost always find that those things, feeding problems and GI distress and reflux, are almost always related. And so whether that's sort of a common cause, or one is causing the other, or it's a really bad cycle, I think those are all things that we need to be thinking about. And certainly if we can find a way to safely feed without thickeners, that should be done.
So Bonnie says, we're moving to a contract with the Enfamil line. I would like to advocate for Dr. Brown for slower flow, less variability. Do you have any thoughts on that?
So that is something that is certainly being done at a lot of places. You know, I'm happy to talk to you offline about that. I've been able to make an argument at many hospitals for the products that are more consistent, even if it means that they are an extra expenditure, because I do think that we'll find, once we have the data, that that will result in babies learning to feed faster. And as we know, that's often the thing that's keeping them in the hospital for that last extra period of time.
Marianne says Avent level 0 per flow chart is slower than ultra preemie, but clinically seems so much faster. Have you heard this?
So, I mean, I've certainly heard from a variety of products that it's, you know, in practice, it seems different. And I guess what I would say is that this probably has something to do with elasticity of the product, or the way, like, you know, the different materials that are used in terms of sort of how easily compressed they are or how elastic they are. And so there are other things that go into it that maybe what you're seeing in practice are taking those things into account when a baby and not a pump is feeding from it.
Do you recommend having the caregivers bring in their home bottle prior to discharge? It's a struggle to get this to happen sometimes. Recommendations? Thank you.
Yeah, absolutely. You know, we need to make sure that babies are safe feeding with whatever they're going to feed with when they go home. And so bringing them in, and this is where sort of making recommendations about products can be helpful for parents, because otherwise they're going to either bring in or use whatever they got at their baby shower, or, you know, somebody told me the other day they picked it because it was top rated on Amazon, you know, and so, you know, but certainly we need to make sure that they're safe feeding on whatever they're going to be feeding on. And I'll mention, so when we send babies home using disposable products, we find them coming back 6 months later and they're still using this, but they're reusing those products over and over and over again. So being really careful about that.
So I see that it's about time for us to wrap up this question and answer session, but I do, because we have such a diverse group of folks on the call tonight, I do have to bring up obviously a therapist question, and that's whether or not you recommend a consult with a speech, what was the other one? It went away. Speech or OT prior to using a thickener.
Oh, absolutely. I think we need to be working really closely in all of our NICUs with our speech and occupational therapists. I think they are incredibly valuable members of the team, and I think we have a lot to learn from each other. I certainly have learned so much from all of my mostly speech language pathology friends and colleagues, as well as OTs who, you know, we bring really sort of different perspectives to the problem, but all with the same goal. And I think teamwork when it comes to feeding is so critically important. So bring in your therapists and absolutely make this a team effort.
Very good. Thank you again very much. We appreciate all you've shared with us so far.